Welcome to Amplify Family Medicine, the official podcast by the Alabama Academy of Family Physicians. In each episode, we dive into the challenges, triumphs, and innovative practices that shape family medicine across our state. Whether you are a medical professional, a student with an interest in family medicine, or simply a health-conscious listener, Amplify Family Medicine promises to provide invaluable insights and inspire action. Let's amplify the impact of family physicians in Alabama together.
Well, welcome to today's episode of Amplify Family Medicine podcast. And tonight what we're going to do is we're going to dive into the 2026 Medicare Physician Fee Schedule. It just came out not too long ago, and really going to look at how is it going to shape the future of family medicine really in 2026, but there's also some good stuff in there that we're hoping is going to shape the coming years as well. Joining us tonight, we've got Tate Gilliard from the AAFP, from the National Academy. And she's going to help us discuss some of the changes that we're seeing, what the implications are for us in practice here in Alabama, and also some challenges that it may present for both patients and physicians. There's some stuff in there we'll talk about. And so we're really happy to have her here today. Kate, thanks for joining us.
Thanks. I'm happy to be here.
Awesome. Well, hey, we're going to kick off and just kind of start at the basics, right? So tell us a little bit about, just in general, what is the Medicare Physician Fee Schedule? Many docs out there may not know what it is, and why is it important for us as family docs here in Alabama and in the U.S.?
Yeah, so the Medicare Physician Fee Schedule is an annual rule that comes out every year, and it sets the reimbursement or payment rates for traditional Medicare Part B outpatient services. So first of all, traditional Medicare, we're not talking about Medicare Advantage, just the basic Medicare, and we're just talking about Part B outpatient. So we're not talking about hospitals or hospital outpatient. We're not talking about skilled nursing facilities, et cetera. But it is the most influential policy for family physicians because most of the services they perform are paid for under this fee schedule. But it's important to keep an eye on this fee schedule because it really is the benchmark for payment policies across the country, be that commercial insurance from employer-sponsored coverage, Medicaid. It is what a lot of insurance companies, employers, state Medicaid departments look to for what are the trends in healthcare and what should payment rates really be.
Yeah. And, I think one of the most exciting things that we saw in it this year, and I think why, we wanted to do this topic, is it's important because this is really like the first time in a little while that we've actually seen a really significant positive update in it. And so I think if you could talk a little bit about like the history there, about some of the cuts, and now we're seeing a good positive update, especially for family medicine, how that's really going to benefit us.
Yeah, so one of the challenges with the Medicare Physician Fee Schedule is it's required to be budget neutral. So every year, CMS has to do whatever they've got to do, pull whatever levers they have to pull to make sure they're not spending more money than they did last year. And the main way they control resources and maintain budget neutrality is through the conversion factor. So the conversion factor is a dollar amount. It's like around $33, and it's what you multiply a CPT code's RVUs by to determine the actual payment rate. So the good news this year is that the conversion factor is going up, which means payment rates are going up. A little bit of a nuance this year that we actually have two conversion factors, one for qualifying participants in advanced alternative payment models and ones who are not qualified participants in advanced alternative payment models. So a really easy way to figure out which one you're in is, are you doing MIPS or are you not doing MIPS? If you're doing MIPS, you're in the lower conversion factor, the non-qualified one. And both conversion factors are going up, but that non-qualified one's going up by 3.26%, and the APM one is going up by 3.77%. And in the world of Medicare payment, those are pretty healthy increases to payment, and that's going to affect every CPT code under the fee schedule. Now, there's a lot of other payment policies at play in this year's rule, so it's not as simple as just saying, oh, I'm getting a 3.26 increase, but that is kind of like the marquee issue in the rule every year, and it's always good to see those conversion factors increasing.
So, above and beyond the positive conversion factor increase, what are some of the other more nuanced changes that we saw in the Medicare Physician Fee Schedule this year around like practice expenses and efficiency adjustments that are really good and also above and beyond what we're going to see in just the percentage changes.
Yeah, so if you're following any of the news around the fee schedule, you're definitely going to hear about two new policies for 2026. The first one is called the efficiency adjustment, and it's getting a lot of chatter up here in DC on Capitol Hill, and across really the healthcare landscape. And the basic premise behind this policy is that when a code is new and it's innovative and it's first valued, it takes longer for physicians to perform a service. But as that code becomes more and workflows become streamlined, physicians get faster, they get more efficient at delivering the service. But the problem is the RUC, which is that volunteer group of physicians convened by the AMA that helps CMS determine values, it usually takes them more than 10 years to revalue a code. So CMS is saying, in a budget neutral system, we need to do better about accounting for these efficiencies. So they are going to apply a very small cut to the work time for certain CPT codes. This is going to result in some of that increase to the conversion factor we talked about. The reason it's great for family physicians and primary care in general is that it's only to non-time-based codes, and E&M codes especially are exempt from this policy. So the main codes we bill are not getting cut, but they are getting the benefit of the increased conversion factor, so better payment. This is something that is facing a lot of challenges on Capitol Hill already. So the AFP has been really doing our job to really defend this good policy because it just makes sense, right? Like in a budget neutral system, you've got to account for efficiencies like that.
Yeah.
Yep. The other policy you mentioned is the practice expense methodology. And this one is going to actually split the family physician community, with the overwhelming majority of folks on the positive side of this. But I do want to be clear that some folks aren't going to get the best end of this policy. But this policy basically relies on the assumption that the practice expense, the cost of doing business, the overhead, the rent, the non-clinical staff you have to hire, it's not the same if you're an independent practice versus when you're in a facility-based setting. So CMS is saying we've always paid the same amount for this part of the CPT code, regardless of the setting, but we don't really think that that's the reality in practice anymore. So they are going to make a reduction to payment via the practice expense portion of a CPT code if you are in a facility-based setting. So that's like hospital outpatient departments, et cetera. But the independent office-based settings are going to be, on the other hand, getting an increase because that practice expense is budget neutral in and of itself. So this is where we're going to see some family physicians potentially getting a reduction in payment. But on the whole, CMS predicts that 58% of family physicians are going to see between a 5 and 10% increase in their RVUs. And that's even before we factor in the conversion factor. So overall, it's really positive for family physicians as a whole.
That's great. Yeah, especially if you're talking about some of that expense methodology with the independent folks, right? Yes, in the hospital outpatient setting, they may see the decrease, but most of those docs are more worried about seeing their patients. And yes, they want to do their RVUs, but that's not as much of their concern a lot of times. So hopefully it'll be the impact of that will be a little bit less. I will mention one thing around the efficiency adjustments. I know I'm also on our AMA delegation for the National Academy, and one of the things that we've been pushing at the AMA is for them to actually use real data to look at some of this stuff, right? And not just these surveys and these, couple of docs over here that are GI say, hey, this is how long it takes me, right? Actually using some, not really in depth, just like start small, right? Start small and use some of that data to really show how much time folks are spending on stuff to make sure it's accurate. Because we know that in the long run, what we're going to be spending the time with the patients, right? And that's really going to benefit us in the long run, which is where we've kind of been left out before. So Medicare, obviously, in the last years has been really working to focus more on preventative care, right? Kind of everything that we're all about at the AAFP and in family medicine. How does what's indicated in the Medicare Physician Fee Schedule this year work on prioritizing that more for our family docs?
Yeah, I think the highlight I would flag for folks there is that CMS is really doubling down on the advanced primary care management codes. These were new for the fee schedule in 2025, so brand new this year, and they provide a monthly payment to cover all of the components of advanced primary care management. Now, what we're going to see new in 2026 is some additional add-on codes for behavioral health integration and collaborative care management. And it really is like the closest thing we have to prospective payment under the fee schedule. And it really is a nod from CMS that they are interested in advancing the way primary care and preventive services are paid for. Additionally, one of the rare places in the rule this year where we saw CMS actually change their mind is that they had intended to remove the social determinants of health screening code. They felt like that was covered in E&M code definitions, and AFP actually pushed back pretty hard on that. We actually had a meeting with CMS on that and explained to them that within the whole, Make America Healthy Again movement, the focus on chronic conditions, you've got to pay people to make these screenings. So they renamed it Upstream Drivers of Health. They tailored the definition a little bit, but they did keep the code in there. And it was really nice to see CMS listening to the feedback from us and others out in the community, and making sure that payment for that service is still included in the fee schedule.
Yeah. And yeah, definitely have been hearing about the advanced primary care management codes. And yeah, I do think this is one of the best signals about, almost the bad word capitation, but somewhere, getting around to that where we're kind of able to take care of patients and kind of giving that money on the front end and kind of giving a little more freedom to take care of people like we know we can do and drive good value and drive good care. So, um, how does some of these changes, especially like APCM, uh, align with any, or maybe even actually, there may be a little bit of a conflict with value-based care and some of the arrangements, some of the way that value-based care is structured today?
Yeah, I think, you've got to look at it as the closest thing to that capitated, like you said, or prospective payment we have under the fee schedule.
Mhm.
And when you look at that, when you zoom out and you look at other things that's happening out of CMS, at the beginning of the year, they canceled some models out of CMMI. They
Mhm.
canceled the Making Care primary model. And it's become very clear, especially now that we've seen this fee schedule final rule and the add-on codes. And CMS flirting with the idea of removing copays for these codes, this is what they see as the primary on ramp for practices who are not really invested in value based care yet. This is your on ramp to begin building the capacities you need in order to potentially participate in MSSP or other value based care models, whether it's CMMI or elsewhere. This is your on ramp. So I would definitely encourage practices to take a close look at those codes and see if they're able to implement them.
Yeah, absolutely. And I live most of my day-to-day world in the value-based care world. And so yeah, it's just definitely as we're heading down this transition, right? Loving those codes. I think they're great. I think they align a lot with what the AFP goals. Sometimes it's a little bit hard because you may be robbing Peter to pay Paul if you're in a shared savings arrangement sometimes. But I think all really, if you look at it from a holistic standpoint, that increased care coordination, that increased touch bases with the patient, all that is it, really going to hopefully drive down a lot more of those expensive services those patients are potentially consuming, end up in the ER when they don't need to, readmissions, ending up in the hospital when they don't need to, which will more than offset, if you're in a shared savings arrangement, extra money you may be getting on the front end, right? So I think that's interesting. I also think it's really fantastic that they're really looking at cost sharing and how that is affecting patients, right? I know that chronic care management, and some of those other things that, even sometimes, some of the other add-on codes are great, but it sometimes is a burden for especially some of our rural patients, right, who may not have as much kind of dispensable income, and we want to use that because it's a revenue driver. It recognizes our value, but it can also upset patients because it can sometimes drive a copay they may have, right, for that, and so that's been troublesome. And I've definitely seen both those sides of it where you know, um, patients, get benefit from it and they see it. But, realistically, if we really want to get them to use it and see the value in it, it's really got to be more so about recognizing it. It doesn't, it's hard because it fits in, they try to put it in a box, is what I tell people. chronic care management is this thing that's in a box, and you can't really go outside the box or else it doesn't work, right? It doesn't. So as we get kind of more like that with APCM, where it's a little more, you have a lot more flexibility in what you can do and how it works, and it's not these check boxes that are got to get done to get your amount of money for the month. Then I think you're right. That is the next step. That's the evolution as we're getting into way more down this pathway with value-based care, right? So, as we're looking at, obviously, this is this year, right? And every year is a little bit different. We've seen that before in the past. What is it that we can encourage our members, encourage the docs across the country? How can they get involved? What can they do to make sure that we continue to see these kind of positive updates with the Medicare Physician Fee Schedule?
Yeah, great question. I would say, first of all, don't wait. Get involved right now because a lot of these policies that we talked about are under threat. There's a lot of groups who don't like things like the efficiency adjustment, and they are going to Capitol Hill right now and asking Congress to intervene and prevent these policies from going into place on January 1st. So at the AFP, we try to make it as easy as possible for our members to advocate. If you go to our website and navigate over to the advocacy part of our website, you can participate in what we call a speak out, which is a easy form letter that will automatically be sent to your members of Congress, letting them know that you support the efficiency adjustment. It's a fair update to payment policy under Medicare, and you don't want them to intervene and block that policy from being implemented. And this is a policy that, one thing I didn't mention earlier is this policy will continue on in perpetuity. Every 3 years, there will be an efficiency adjustment for codes that haven't had that new data to demonstrate that their value is accurate. So this is a policy that's going to benefit primary care, like I said, in perpetuity. So we've got to make sure it gets implemented on January 1st. So don't be afraid to speak up and defend the policies. I know members like to advocate when they hear about something they don't like, but it's just as important to advocate when you hear about something you do like.
Absolutely, absolutely. When we talk to legislators, both state and federal levels, right? They sometimes say, "Hey, I'm not hearing from people about this, good or bad," right? So it doesn't take a lot of effort to just do those quick little things, and that they do move the needle, right? They do. Hey, we've gotten, you know, 15 emails on this, 20 emails and phone calls and whatnot. And certainly, if you have a relationship with staffers or whatnot, please, please, please utilize those. Be a resource for those people. Um, work with the academy, work with us here in the state, work with the national academy to let them know, hey, I know these people, I know some of their staff. That way, those are great relationships that we can rely on to really, get our story out there about what this is doing for their constituents, which are our patients, right, as well as the businesses that a lot of our folks are running, that are making jobs in their communities, right, and continuing to tell that message always resonates with any legislature. Last question for you, before we wrap up is it's not really on the fee schedule, but the government shutdown just ended, thank goodness. And with that came the extension of the telehealth waivers, right? And so big issue for a lot of family docs going all the way back into COVID, right? We kind of got, and patients too, patients love it as well, right? So just talk a little bit about that and what it means for us.
Yeah, very relieved here in DC that the federal government shutdown is finally over. As you mentioned, telehealth is now back in play. Those extenders have been extended. There was obviously a claims hold. Folks are probably aware of CMS at first was just holding telehealth claims. Then they went ahead and sent them back to docs. You should now be able to submit those claims and get paid for them. CMS should automatically reprocess them. And another policy that was extended that's of particular good news to rural docs is a policy that I won't get too far into the weeds on, but it's the GPCI work floor policy, and it basically ensures there's an extra payment bump to folks in rural areas. So that policy had been temporarily suspended during the shutdown. If you're in a rural area, you might have seen your payments decrease a little bit. They should get reprocessed. You should get back pay for that. And moving forward, you should be getting that higher value reimbursement from Medicare. So all good news. Happy to see the government back open and functioning again.
Exactly, exactly. Yeah, we're still kicking the can down the road a little bit with telehealth, but hopefully we'll get to some point where it becomes kind of ingrained in the system, and I think enough patients and enough physicians like it that I think hopefully it's going to be around for the long term. So, well, Kate, thank you for joining us. It was a great talking to you. Love hearing all your perspective from your work with the Academy and up in DC. And as we talk about this really positive update for docs, I know whether it's here, whether it's at Congress of Delegates or on the AMA House of Delegates or in the state, like it's one of the things we talk about all the time, right? It's making sure that we can, sustain these businesses to continue to take care of our patients. So, and for folks out there to listen, if you'd like more information or any more resources, the AAFP's website has tons of resources on that. And any more detailed updates, you can sign up for things like advocacy ambassadors and the news alerts and whatnot that can keep you up to date on those kinds of things, right? And then also here, don't forget to subscribe and stay updated for anything that's impacting us in family medicine here in Alabama and beyond. And thank you very much.
Thanks for having me.